This is the ATI Maternal Newborn Chapter 22, Postpartum Mental Health Disorders. Postpartum blues can occur in up to 85% of clients during the first few days after birth and generally continues for up to 10 days. It is characterized by mood swings, anxiety, feelings of sadness, crying, insomnia, and a lack of appetite. Postpartum blues typically resolve in 10 days without intervention. Postpartum depression, or PPD, occurs within 12 months of birth and is characterized by persistent feelings of sadness and intense mood swings. Depression and anxiety occur in 8% to 20% of new parents and usually do not resolve without intervention. It is similar to non-postpartum mood disorders. According to ACOG, perinatal depression has been identified as one of the most common medical conditions during pregnancy and the postpartum period. It affects 1 in 7 clients. According to A1, perinatal mood disorders, or PMS, can occur anytime during pregnancy and during the first year postpartum. These include depression, bipolar disorder, anxiety, and postpartum psychosis. Postpartum psychosis develops within the first 2 to 3 weeks of the postpartum period. Clients who have a history of bipolar disorder are at a higher risk. Clinical findings are severe and can include confusion, disorientation, hallucinations, delusions, obsessive behaviors, and paranoia. The client might attempt to harm themselves or their newborn. A nurse should monitor clients for suicidal or delusional thoughts. The nurse should monitor newborns for failure to thrive, secondary to an inability of the parent to provide care. Risk factors: hormonal changes with a rapid decline in estrogen and progesterone levels, individual socioeconomic factors, decreased social support system, anxiety about assuming new role as parent, unintended pregnancy. Expected findings: postpartum blues, feelings of sadness, lack of appetite, sleep pattern disturbances, crying easily for no apparent reason, headache, anxiety, anger, and sadness. Postpartum depression, feelings of guilt and inadequacies, irritability, anxiety, fatigue persisting beyond a reasonable amount of time, persistent feelings of sadness, intense mood swings, thoughts of harming newborn or self. Physical assessment findings: crying, weight loss, flat effect, irritability, severe anxiety attack. Postpartum psychosis: pronounced sadness, disorientation, confusion, paranoia, and rapid mood swings. Physical assessment findings: behaviors indicating hallucinations or delusional thoughts of self-harm or harming the newborn. Patient-centered care, nursing care. All clients should receive an assessment throughout pregnancy and during the postpartum period for perinatal mood disorders. This assessment should include questions that address the client's mood and anxiety. This screening is recommended by ACOG. Postpartum depression should be assumed during the postpartum period before discharge and then reassessed 4 weeks after birth. Monitor interactions between the client and their newborn. Encourage bonding activities. Monitor the client's mood and affect. Encourage the client to communicate feelings, validate and address personal conflicts, and reinforce personal power and autonomy. Ask the client if they have thoughts of self-harm, suicide, or harming their newborn. Medications. Antidepressants can be prescribed by the provider if indicated. Antipsychotics, benzodiazepines, and mood stabilizers can be prescribed for clients who have postpartum psychosis. Client education, care after discharge. Get plenty of rest and nap when the newborn sleeps. Remember the importance of taking time out for yourself. Schedule a follow-up visit prior to traditional postpartum visit. Consider the community resources and seek counseling and consider social agencies as indicated.